This section explains why a CT image is computed rather than photographed. A CT image is never seen. It is solved. The X-rays passing through the body record only line integrals of attenuation along each ray, so no single projection reveals any interior voxel on its own. Here is the move that makes the whole method work. Rotate the source and detector pair, collect projections from every angle, and the interior density field becomes recoverable by inversion. This is the radon transform run backwards, with filtered back projection as its first workhorse. Each solved voxel then reads out in Hounsfield units, a scale pinned so that water sits at 0, air at -1000, and bone at +1000. Grasp that one move from boundary measurements at many angles to the interior field, and the chapter's whole zoo is just engineering variation on the same inversion, single slice versus multi-slice, dual energy, iterative reconstruction, and the clinical modes of non-contrast CT, CT angiography, and perfusion. This part explains what modern MRI methods do differently from weighted imaging. Weighted MRI measures a confounded product. The signal entangles the intrinsic tissue parameter you want with the pulse sequence and the scanner's hardware quirks. So a T1 weighted image is only tuned toward T1, never a reading of it. The number won't survive a change of coil, of center, or of day. The chapter's whole thesis is one move. Instead of tuning contrast to a regime, you invert the signal equation and solve for the intrinsic quantity itself, T1, T2, and proton density as absolute apparatus-free values. Once you have the invariant, rather than a weighting of it, comparison across patients, across time points, and across machines becomes meaningful. Everything after is just fast enough ways to sample the recovery curve, to make that inversion clinically affordable. This section explains how magnetic resonance spectroscopy turns the same nuclear spin that MRI uses for anatomy into a chemical assay, keeping exactly the physics that MRI discards. Place a nucleus in a field B, and it resonates at a frequency omega equal to minus gamma times B. MRI treats that as one clean water peak and maps where the protons are. But the field a nucleus actually feels is shifted by its electron cloud, the chemical shift, and by its bonded neighbors, the J coupling. So each metabolite resonates at a slightly displaced frequency, a spectroscopic fingerprint. MRS reads what molecules are present and at what concentration, non-invasively, from the peak positions and amplitudes. The generative move, the frequency perturbation that MRI averages away as noise, is the entire signal here, figure and ground swapped on one substrate. This section explains how diffusion, magnetic resonance imaging reads. Tissue structure from the motion that structure forbids. Structure is read off the motion it forbids. Water molecules jitter thermally in every tissue, and magnetic gradient pulses phase label that jitter, so the signal attenuates in proportion to how far the molecules wandered. Only incoherent wandering counts. Coherent flow stays invisible. The trick is that barriers you cannot image betray themselves through anisotropy. Along an axon, water diffuses freely. Across it, the membrane hinders, so the signal loss becomes direction dependent. Measure the attenuation along enough orientations and you recover the geometry that constrain the random walk, the cell size, and the fiber direction without ever touching the random walk, the cell size, and the fiber direction without ever touching the tissue. Here is the whole arc of the chapter. Diffusion is a probe whose forbidden directions map the microstructure, the drop of ink ellipsoid made quantitative. This section explains magnetization transfer imaging. Standard MRI sees only the mobile water protons. The protons locked into macromolecules, into myelin, membranes, and large proteins, relax too fast to register at all. Magnetization transfer reads that invisible pool by proxy. You strike it with an off-resonance radiofrequency pulse that it alone absorbs, you saturate it, and you let the saturation bleed into the water through proton exchange. The observable water signal drops, and the depth of that drop, the MT ratio, reports the macromolecular content no scanner can image directly. The MT ratio is the quantity M0 minus MS, all divided by M0. The generative move is this: to measure a hidden reservoir, couple it to a visible one, and watch the coupling drain it. Contrast becomes a titration of an exchange, a reading of coupling as it happens rather than a still snapshot of how much is present. This section explains cerebral perfusion imaging as a single inverse problem shared by every modality. Perfusion. The volume of blood delivered per unit tissue per unit time is never seen directly. You watch a tracer pass through each voxel and infer flow from its concentration versus time curve. The whole chapter reduces to one relation. Tissue concentration is the arterial input convolved with the residue function, scaled by flow. Written out, the tissue concentration equals the cerebral blood flow times the convolution of the residue function with the arterial input. Recover flow by deconvolving against the arterial input. Blood volume then falls out as an area ratio and mean transit time as volume over flow. That last identity is the central volume theorem. Every modality is the same inverse problem. Dynamic contrast enhanced imaging, dynamic susceptibility contrast, arterial spin labeling, CT, and PET. They differ only in which tracer they use and which physics renders it visible. This part explains what functional magnetic resonance imaging, fMRI, actually measures. The thing it measures is not neurons, but the magnetism of blood. Deoxyhemoglobin is paramagnetic. It distorts the local magnetic field and shortens the signal's decay time, called T2 star. Fire a population of neurons and the vasculature over-responds. Blood flow surges past the actual oxygen demand, flushing deoxyhemoglobin out. Less field distortion, longer T2 star, a brighter voxel. The entire method is that one inference chain read backwards. Activation leads to a flow surge. The flow surge leads to a paramagnetic washout. The washout raises the local T2 star, and that rise becomes a detectable signal. Everything downstream in the chapter follows from one fact: that the signal is a vascular echo of firing and never the firing itself. The roughly 5-second peak of the hemodynamic response, the millimeter blur, the caveat that the measure is a surrogate and not direct, all of it comes from that. This section explains the core structural idea behind brain single-photon emission computed tomography imaging. A gamma-emitting tracer is injected so that it binds a chosen physiological target. Its unknown three-dimensional concentration must then be recovered from two-dimensional projections, the directional shadows that the rotating gamma camera collects all around the head. This is an inverse problem. You reconstruct an interior emitter field from its integrals along many viewing angles. It is exactly the tomographic move that CT makes. But here, what is imaged is function, neurotransmission, and perfusion, rather than anatomy. The constraint that governs everything is that photons have no lens. Direction is recovered only by the collimator, a lead grid that absorbs every photon not traveling parallel to its holes. So the whole modality throws away most of its signal to buy geometric direction. Sensitivity is spent for resolution. This section explains what positron emission tomography really measures and why its numbers live or die on correction. A positron annihilation throws two 511 kilo electron volt photons back to back. Catch both in coincidence and you have drawn a line through the point of emission. Stack millions of such lines and you would have the tracer's distribution, except you do not. What you actually measure is that distribution corrupted by known physics. Scattered photons land in the wrong position, uncorrelated pairs, fake coincidences that never happen together. Attenuation swallows counts before they reach the detector. So the real content of PET is the inversion, subtracting each corruption to recover a physiological rate, such as glucose consumption or receptor binding. The chapter's thesis is that a PET number means only as much as its correction chain is faithful. The discipline lives in quantification, the recovery of a true rate, rather than an acquisition. The recovery of a true rate, rather than an acquisition. The raw catching of photons. From here, you can predict the rest. Every named method in the chapter is one more distortion being undone. This section explains how a single physical primitive generates the entire ultrasound instrument. Fire a pressure wave into tissue, then time its echo. Distance falls straight out of the round-trip time because soft tissue passes sound at a fixed speed of about 1,540 meters per second. From that same returning wave, two more readings emerge. The amplitude of the echo paints the grayscale anatomy. The frequency shift of the echo, known as Doppler, reads blood velocity. One wave, three signals, timing gives distance, loudness gives structure, pitch change gives flow. Everything else is one governing trade-off. Resolution scales with frequency, and penetration works against it. So you buy fine carotid detail at 5 to 13 megahertz, and you reach the circle of Willis deep in the brain only at 2 to 4 megahertz. That trade-off is why neurosonology earns its place as an extension of the neurologic exam. It is a bedside, non-invasive probe with a time resolution no other modality matches, limited only by bone and by the operator's own command of anatomy. This chapter explains how functional imaging locates the source of a primary headache. The core idea is simple: where a headache hurts is not where it comes from. The single move is that functional imaging relocates the generator of primary headache from the aching periphery to central regulators. It does so by exploiting what peripheral pathology cannot fake. Cluster headache's circadian and seasonal rhythmicity forces the cause inward to the hypothalamus, the body's clock. All 10 years to the hypothalamus, the body's clock. Migraine's dorsolateral pons stays lit after successful treatment abolishes the pain. So the brainstem is the generator, not the consequence. The invariant runs like this. Find the region whose activity tracks the attack, yet outlives the symptom. And you have found the machine that starts it. Everything else is downstream of that one inference, the shared hypothalamic signature across the trigeminal autonomic cephalalgias, and the pain network activation. This section explains why curing drug-resistant focal epilepsy is fundamentally a detection problem. Cure in drug-resistant focal epilepsy reduces to one act: excise the lesion completely and the seizures stop. The chapter is therefore a detection problem, and its central surprise is this. In up to half of surgical candidates, conventional MRI reads normal, while the resected tissue under the microscope is unmistakably diseased. The lesion is present, but below the eye's threshold. Every advanced method performs one move. Volumetry, surface morphometry, and texture classifiers, reading features no human can resolve. all do the same thing. They raise sensitivity until subthreshold signal crosses into the detectable, turning an inoperable MRI negative patient into an operable one. Detection here already is treatment. The computation is a prosthesis for the reader's eye. This section explains how imaging reads the grade of an adult tumor when no tissue is in hand. Tumor grade is a histological verdict. It rests on proliferation, mitotic index, and anaplasia, and it needs a specimen. WHO grading cannot proceed without one. The chapter's generative move is this. Every advanced imaging modality substitutes a physical correlate for that missing tissue. Grade tracks cellularity and neovascularization, so measure those directly. Perfusion reads capillary density as elevated blood volume and flow. Diffusion reads cellular packing as restricted water motion, giving a low ADC in the hypercellular grade 4 and a high ADC in grade 2. Read the latent variable through a measurable one. And because a scan samples the whole heterogeneous mass rather than one biopsy core, the proxy escapes sampling error. The organizing spine is the surgical timeline. Diagnose, resect, follow, with imaging serving each phase. This section explains why brain infections are diagnosed through anatomy rather than through the organism itself. Infection is invisible to MRI. What enhances is the breach. Contrast leaks wherever the blood-brain barrier has failed, so the image records the damage while the organism itself stays unseen. The chapter's move is to make the meninges a coordinate system. There are 6 nested layers and potential spaces running deep to superficial, the pia, the subarachnoid space, the arachnoid, the subdural space, the dura, and the extradural space. Every infection localizes to one compartment. Which compartment enhances, and in what pattern, whether linear leptomeningeal, nodular, or pachymeningeal, read against the CSF signature, triangulates the pathogen class before any culture returns, so the differential becomes a lookup indexed by anatomy. Name the space the enhancement occupies, and you have narrowed the organism. The anatomy section is the diagnostic algorithm itself. This pod explains how multiple sclerosis is read on imaging and why the standard MACA falls short. Multiple sclerosis reads on MRI as bright T2 spots scattered in the white matter, and diagnosis is just proving those lesions are disseminated in space, meaning multiple characteristic sites, and in time, meaning a new one appears later. That criterion is the spine of the chapter. The surprise that reorients everything is the clinical radiological paradox. Conventional MRI is exquisitely sensitive, yet the lesion count barely predicts disability. The reason is degeneracy. One hyperintensity is a many-to-one map over heterogeneous pathology, edema, demyelination, axonal loss, and it says nothing about damage outside the focal lesions. So the chapter's real project is the search for a less degenerate marker, quantitative MR bound more tightly to the tissue substrate than a bright blob can ever be. This section explains why every stroke image is really a clock, and how each scanning method reads the same underlying event. Every stroke image is a clock reading one physical cascade. Ischemia shifts water from outside the cells to inside them, and each modality is just a sensor with its own lesion up, lighting the lesion up and its own specificity onto that same shift. CT senses bulk density and lags behind. C2 and flare sense free water accumulating over hours. DWI senses the diffusivity drop from cytotoxic edema almost at once, within 45 to 90 minutes. So the finding is not a picture. It is a timestamp on tissue fate. The chapter's real move is this: imaging that is sensitive enough redefines the disease. A DWI-positive lesion is stroke, regardless of how briefly the symptoms lasted. From this, you can predict any sequence's arrival time. Ask which physical proxy it tracks, and ask when that proxy crosses its threshold. This section explains how vascular dementia is diagnosed from imaging and why the diagnosis rests on structure rather than function. Vascular dementia is diagnosed by counting damage, not by reading a signature. Structural MRI and CT enumerate discrete lesions, territorial infarcts, lacunes, white matter changes, and microbleeds. The criteria simply tally these against thresholds: 25% white matter involvement and 2 or more lacunes. Functional imaging ought to sharpen this, since vascular dementia is a perfusion pathology. Instead, it dissolves it. SPECT and PET hand. Alzheimer's disease and frontotemporal dementia clean, localized hypoperfusion fingerprints. Yet vascular dementia returns only patchy, heterogeneous, faintly frontal reductions and non-pattern reductions. The inversion is the whole chapter. The one dementia defined by Bessel failure is precisely the one that blood flow imaging cannot fingerprint. So structure carries the diagnosis, and function merely excludes the lookalikes. This section explains why Alzheimer's imaging is an attempt to see a hidden disease before it announces itself. Alzheimer's is a pathology that runs decades ahead of its symptoms. Tangles and amyloid accumulate, neurons die long before memory fails. So the whole imaging program is an act of making a latent process observable before it declares itself. The chapter's move is to factor that hidden process onto 2 orthogonal axes. The first axis is biomarkers of state, amyloid burden, PET tracer retention, and low CSF amyloid beta 42. The second axis is biomarkers of stage, neuronal injury, elevated tau, temporoparietal, FDG, PET hypometabolism, and medial temp and temporoparietal FDG. Diagnosis stops being a matter of waiting for dementia and becomes reading a 2-coordinate matrix. Both axes negative rules, Alzheimer's out. Both axes positive is high likelihood. Imaging relocates the diagnosis upstream to where the disease actually begins. This section explains why one molecular disease shows up so differently across the brain. A diffuse molecular lesion writes itself onto the brain selectively, and that is the whole move. 3 proteinopathies, tau, TDP for the hippocampus, while each aphasia, subtype E43, and FUS underlie one clinical spectrum. Yet each syndrome collapses a specific network. The behavioral variant of FTD dissolves the medial frontal orbitoinsular anterior temporal circuit, worse on the right, taking the amygdala before the hippocampus, while each aphasia subtype erodes its own language territory. So, topography inverts to pathology. Where the tissue thins predicts which protein aggregates in vivo before autopsy. The chapter's function in the book's arc is to establish that neuroimaging is not confirmation, but stratification, reading atrophy and network signatures to sort a molecularly heterogeneous disease into treatment trial cohorts. Predict the next case by asking not how much atrophy, but which network first. This section explains how dementia with Lewy bodies is diagnosed, a dementia that has no positive image of itself. Dementia with Lewy bodies, DLB, is read entirely by what has gone missing. Each scanner subtracts a different loss against the Alzheimer's baseline. The disease never announces itself by something present. It is inferred from a pattern of things absent. Consider what each scan reveals by its silence. The dopamine transporter is absent from the putamen and the caudate on the FPCIT scan, the same nigrostriatal loss shared with Parkinson's. Occipital metabolism is gone while the medial temporal lobe stays intact, the exact inverse of the atrophy signature in Alzheimer's disease, where the medial temporal lobe is the part that wastes. No tracer lights up a thing that is there. Diagnosis is the intersection of deficits, and the specificity comes from which absences co-occurred together. It is the combination of losses, not any one loss alone, that names the disease. Here is the generative primitive. When a disease has no marker of its own, image the differential instead. The discriminating signal lives in the pattern of subtractions, not in any single presence. This section explains how the Parkinsonisms are told apart. Working at the structural level, every Parkinsonism converges on one lesion. The dopaminergic neurons of the substantia nigra die, their striatal projections thin, so the tracer imaging that loss localizes the disease but cannot name it. Discrimination lives where the syndromes diverge downstream of the shared lesion. Postsynaptic. D2 receptors stay intact in idiopathic PD, and they degrade in MSAP and PSP, SP. Glucose metabolism covariance patterns, the PDRP, fingerprint each one. The chapter's move is to read a layer the clinic cannot. Lewy bodies confirm PD only at autopsy, so imaging becomes the in vivo surrogate for histology. The same primitive runs throughout. To separate diseases sharing a final common pathway, probe upstream for what they share, and downstream for what tells them apart. This section explains why prion disease is imaged live at the level of its microscopic cause, rather than through the damage it leaves behind. Prion disease teaches a single move. Pick the imaging channel, whose physics couples directly to the pathology's microstructure, and the readout becomes the lesion itself rather than its aftermath. Spongiform degeneration fills dendrites with fluid vacuoles small enough, roughly 16 micrometers across or less, to cage the Brownian motion of water. Diffusion-weighted MRI reads exactly that restricted motion. So the bright signal on DWI is the vacuolation itself, seen before atrophy or any T2 change, and beating every CSF marker and the ET2 change, and beating every CSF marker and the EEG. Other dementias are imaged by their late structural loss. Here you image the microscopic cause live. One boundary proves the reading. Bright DWI can leak from mere T2 shine through, the brightness bleeding across from the underlying tissue signal. So, genuine restriction must be confirmed, dark on the ADC map. The physics of restricted water is what carries the diagnosis. The glow on its own does not. This section explains why imaging in motor neuron disease works backwards. Motor neuron disease has no positive test, and the dying neuron leaves conventional MRI nearly blank. So the value of imaging inverts. It first earns its place by excluding the mimics that wear the clinical face of the disease, compressive myelopathy, MS, a tumor. Only then do the non-conventional sequences convert that negative into a graded positive. These are diffusion tensor, MRI, cortical thickness, and spectroscopy. They read degeneration quantitatively, where the clinical exam only guesses. The thread they follow is anatomical, the corticospinal tract running from the precentral cortex down through the internal capsule, It spreads too into frontotemporal gray matter as pure ALS shades toward FTD along one continuum. The lesson generalizes. When the pathology is functional loss, the image certifies absence before it measures presence.